Good afternoon and welcome to the Department of Medicine Grand Rounds and the first day of spring. May not feel exactly that way, but today we're very excited. Our speaker is Dr. Patterson. Sarah is an adult benign hematologist at Hamilton Health Sciences and an assistant professor in hematology at McMaster University. She completed her medical training at Queen's University as well as at McMaster. And she also completed a fellowship in red cell disorders. She works at the McMaster Hemoglobinopathy Clinic as part of the multidisciplinary team that cares for patients with hemoglobinopathies and other red cell disorders. She has an interest in health policy and is currently completing master's degree in health system research. Very exciting. Her research interests include promoting health equity and quality of care, especially among patients with red cell disorders. It's not a surprise that Dr. Patterson today is going to speak to us about a curative therapy in red cell disorders. Very exciting. Welcome, Dr. Patterson. And without further ado, we'll start the rounds. Please go ahead, Sarah.
All right. Thank you very much. Do we have a land acknowledgement? Is that a thing?
Yes, that's correct.
So I don't actually have a text for a land acknowledgement is the thing, but we are definitely privileged to provide care on lands that Indigenous people have called home for thousands of years. Is there a more text version of that?
That's very appropriate, Sarah. You can carry on with your words.
Thank you. Then I will dive in. I'm going to turn off my camera if nobody minds, just to make sure that the feed is as clear as possible. So today I would like to take us through a really quick tour of curative therapies for red cell disorders. I have a couple of disclosures which are not relevant to this talk. I am a participant on the National Ad Board, which is compensated for Reblozyl or luspatercept, which is a therapy in beta thalassemia major, as well as a local sub-investigator on an Activate study, but neither of these is relevant to our talk today. I'm going to take you through really quickly a brief review of what thalassemia and sickle cell disease is. And why curative therapies are important. I'm going to talk very briefly and somewhat superficially about curative therapies that we have, which are gene therapy and stem cell transplant. And then I wanted to talk a little bit about some of the barriers and opportunities that exist in our Canadian context, and hopefully lead to some great discussion. No talk on hemoglobinopathies can start without talking very briefly about normal hemoglobin. Our normal hemoglobin has 2 alpha chains and 2 beta-like chains. In adult hemoglobin, that is 2 beta chains. In fetal hemoglobin, that's 2 alpha chains and 2 gamma chains. And these globin chains are associated with iron molecules that help carry oxygen through the body. You can see here in the sort of graph, the hemoglobin A, which is your adult hemoglobin, hemoglobin A2, and hemoglobin F, or fetal hemoglobin. And you can see how newborns have predominantly fetal hemoglobin, and around 6 months of age, that should have shifted to adult hemoglobin or hemoglobin A. That's normal. What about pathology? So the 2 hemoglobinopathies I'm going to talk about today are sickle cell disease and thalassemia, mostly thalassemia beta major, which is now transfusion-dependent thalassemia. Sickle cell disease is a mutation in the beta hemoglobin chain. It's a point mutation that has a substitution of a glutamine to a valine, And that single amino acid change allows for that hemoglobin molecule to polymerize in long chains. And these long chains are so long and rigid enough to actually change the structural conformation of the cells. It changes them from a nice round biconcave disc that's flexible and able to carefully navigate the capillaries of the body into a pointed end shape that looks like a sickle, like the farm instrument. And that's where it gets its name. And this long, pointed, sharp blood cell can get stuck in the small vasculature of the body, leading to many of the complications we know, and which I will discuss shortly. Thalassemia and thalassemic mutations are mutations in the hemoglobin genes that result in either a reduction of production of hemoglobin or a lack of production of functional hemoglobin. This can happen in a number of different ways, including fusion proteins like hemoglobin constant spring, which is an alpha mutation. For the purposes of this talk, we're generally talking about transfusion-dependent beta thalassemia major. And that's mostly because that is a problem at about 6 months of age when that hemoglobin shift from fetal to adult happens, as opposed to alpha thalassemia major, which is fetal hydrops, which becomes an issue partway through pregnancy because that fetal hemoglobin that you require for the later half of pregnancy and fetal development requires alpha chains. So I'm not really talking more about alpha thalassemia, but I just sort of want to say it's also a thing. Both transfusion-dependent thalassemia and sickle cell disease have multiple complications, and this is why we need to have specialized care and specialized care clinics like the McMaster Hemoglobinopathy Clinic. Sickle cell disease is associated with those little tiny blood cells getting stuck in many places in the body, and that can cause vaso-occlusive pain. It can also cause retinopathy. It can cause strokes, which can be either ischemic or hemorrhagic. These patients can get avascular necrosis. They can have, they generally have functional asplenia or splenic infarction by the age of 10. There are many complications from head to toe associated with significant morbidity as well as early mortality in sickle cell disease. Thalassemia likewise has head to toe complications. Often these present in very young childhood when the babies are failing to grow. They can have facial deformities like frontal bossing from the bone marrow expansion that is happening as the bone marrow is trying really hard to make hemoglobin that there's a genetic issue with. This can lead to extramedullary hematopoiesis or bone marrow growth outside of the bone marrow, which can cause splenomegaly. It can cause growths on the side of the spine that can lead to compression of nerve roots. Some of the complications of thalassemia are related to the treatment, particularly transfusion with transfusional iron overload, as well as things in the past, more issues with infections like hepatitis than now, thankfully, to all of the hard work that Canada Blood Services has done. There's about 40,000 infants in the world born with beta thalassemia every year, and about 25,000 of those have transfusion-dependent beta thalassemia. This slide shows exactly the same thing, so we're going through it very quickly, and I'd just like to highlight the fact that endocrine dysfunction and iron overload are fairly common between sickle cell and thalassemia, as well as the risk of thromboembolism due to chronic hemolysis. So both these diseases have significant complications. I told you briefly about the numbers for thalassemia, but I want to sort of talk about sickle cell in a little bit more detail, thanks to Dr. Pendergrast and this OHIP data type trial that looked at 10 years of experience in Ontario and shows that in Ontario, there's about 3,400 unique patients with sickle cell disease who had an average of 2 ED visits per median through this period time. the thing that I really was struck by was through this 10-year period, the average age at death, and about 6% of patients in this trial died, not trial, this retrospective review died during the 10-year study period, and that was at 55 years. So sickle cell is associated with early morbidity, and this is data from Ontario with the care that we're able to provide. It's all fine and great to have numbers and to talk about organ damage and to talk about how sick patients with sickle cell disease can be, but sometimes I think a picture is worth 1,000 words. Hertz Nazaire is a Haitian artist who has lived experience with sickle cell disease, and I just think these are really beautiful representations, really powerful representations of what the experience of living with this disease is like. It's not all hopeless. We do have treatments, and the treatments that we provide at the McMaster Hemoglobinopathy Clinic are displayed on this slide for the most part. In sickle cell disease, most of our disease-modifying therapy is with hydroxyurea, which is an oral medication originally used and still used in some chemotherapy settings, particularly for myeloproliferative neoplasms. It works through multiple mechanisms, notably by increasing fetal hemoglobin, as well as having some stability and red blood cell stabilization that can help reduce hemolytic rate. It has a vasodilatory effect through a nitric oxide moiety. And overall, hydroxyurea has been shown to slow the onset of organ damage and really increase the quality of life and appears to increase the quantity of life of people living with sickle cell disease. We also use transfusions to suppress hemoglobin S, which could be simple transfusions where we give a blood transfusion, or an exchange transfusion where we take out blood and give blood back to keep a net similar hemoglobin level, or for iron reduction. We particularly use this in people with stroke or acute organ damage like recurrent acute chest syndrome, etc. There are other agents, but they're not disease modifying, so I'm not talking about them like crizanlizumab, for example. The mainstay of thalassemia is transfusions, and these transfusions are primarily to suppress ineffective erythropoiesis and maintain adequate hemoglobin for growth and function. We start transfusions in patients who have failure to thrive or who have low baseline hemoglobins and require additional suppression or adequate hemoglobin as young children, and this leads to iron overload pretty quickly. So they're often started on chelation agents through our pediatric colleagues. There's a few other treatments like luspatercept, but they're not related to curative treatment or particularly disease modifying. So again, I'm not talking about them. So that's great. We do have treatments. For sickle cell disease, you have a pill that you have to take every day for the rest of your life with frequent blood work monitoring once a month, once every 3 months, depending on dose changes and response. Maybe you have transfusions for your sickle cell or your thalassemia, and you have to come once a month to a hospital. You have to wait for your group and screen. You have to wait for the blood to come, spend hours having it infused, undergoing this procedure, and missing at least a day of work every month, if not more. Importantly, particularly in sickle cell disease, even with perfect therapy, even on exchange transfusions with hydroxyurea, even if you do everything perfect, it doesn't necessarily protect you from all pain crises or all organ damage. I do have a slide about the locations of specialty clinics, but if you have a disease like transfusion-dependent thalassemia or sickle cell disease, you should have care shared with an expert clinic, and there's only 13 of those across the country. If you want to travel and spend 3 months living in another country and you have transfusion-dependent thalassemia, there's a lot of paperwork that needs to be done. What I'm hoping this slide shows is a little glimpse into the life of what it's like to live with thalassemia or sickle cell disease. And yes, we have good treatments, but they're not cures. And there's a lot of sort of daily and ongoing maintenance for your entire life that could potentially be addressed with curative therapy. So this is a whirlwind tour. It's quite quick. And it's somewhat superficial because I am not a transplanter, nor do I administer gene therapy. But I'd like to give you a bit of an introduction as to what it is and how this works. I'm going to talk about stem cell transplant first, and then about gene therapy. In terms of stem cell transplants, the stem cell transplant of choice is an allogeneic or from somebody else stem cell transplant. And that starts with step one, where your donor gets treatment to release their blood cells into their bone marrow hematopoietic stem cells into the blood so that we can collect it with an apheresis machine. Because most people prefer to donate stem cells through their peripheral blood rather than bone marrows. These stem cells are collected with an apheresis type machine and selected using advanced techniques for CD34 positive cells. For a straight transplant, these stem cells are frozen. The patient is brought to clinic when they're ready. There is some pre-transplant workup required, usually transfusions, to suppress ineffective erythropoiesis, as well as suppress hemoglobin S in sickle cell patients in order to have the best protection through the transplant period so that they don't have vaso-occlusive pain crisis or complications. So these patients come in, they get ready for their conditioning, which is chemotherapy or chemo and radiation, which is set to make space for the new graft to come in. And then there's a period of time while that graft regrows, where that bone marrow is able to expand and start making blood, where the patient is monitored and often on immunosuppressant drugs. That's transplant. Gene therapy is essentially an autologous or self-donation, where the donor is the patient itself, themselves, who is collected for stem cells, which are then sent off for processing for the gene therapy part, and then frozen and sent back, at which point the patient has conditioning, the cells are reinfused, and then there is a period of time when that graft is able to regrow. A lot of overlap between stem cell and gene therapy. I have some numbers because I like numbers. This slide is specifically to point out the small number of non-malignant diagnoses stem cell transplants that were conducted in 2021 in the USA. This is the most recent research I was able to pull from the Center of International Blood and Marrow Transplant Research Group. And there's a number of slides from them. So you can see that many malignant conditions are having a lot more stem cell transplants than are non-malignant diseases in adult populations. They didn't have a breakdown I could find of adult population non-malignant transplants, but in the pediatric group, you can see that hemoglobinopathies like sickle cell disease and thalassemia together are about 1/4 of non-malignant transplants, stem cell transplants for pediatrics in 2021. So there's a reasonable cohort, but it's not big numbers by any means. Does transplant work? Yes, and actually quite well. Stem cell transplant is the only approved curative therapy in Canada at this time. Stem cell therapy can result in greater than 90% overall survival for both sickle cell and thalassemia, as well as disease-free survival, so a lack of transfusions, particularly in thalassemia, and a lack of ongoing organ damage and pain crises, and sickle cell of greater than 80 and 92%. Here, I have some more pictures to show some results of where I got these numbers. I'm going to talk a little bit more about acute and chronic graft versus host disease very briefly upcoming, but this is where the new graft, whether it's somebody else's stem cells or the gene therapy graft, gene therapy is an autologous transplant. Allogeneic transplant where your graft is from someone else, sometimes that new immune system doesn't recognize the body as self. And that leads to graft versus host disease. Graft versus host disease can affect the whole body. It can affect the skin. It can affect the brain. It can affect the lungs, and it can cause significant damage. And it's one of the scarier side effects and concerns about doing non-malignant transplants, because these patients are suffering from morbidity and potentially early mortality due to their underlying non-malignant condition. But the risks of their condition without transplant are different than somebody with acute myeloid leukemia, for example. Transplants are more challenging in people with organ damage. So there's a lot of push to try to do transplants in people with sickle cell or gene therapy at an early age. Often that is before puberty, and that has some implications on fertility. I'd like to point out that the existing damage, so if somebody has evidence of organ damage, a transplant or gene therapy is not likely to reverse this damage. So we do want to catch people when they're healthier if we can. We do not expect curative therapy to reverse existing damage. This slide is from a 2022 systematic review. And I'd just like to point out that it has data from 2016 to 2020 for different types of donors. Matched sibling donors are at the top here with an overall survival of greater than 90%, an event-free survival of greater than 83%. So that's your lack of transfusions, lack of pain crises, because this includes both sickle cell and thalassemia transplants, with graft versus host disease rates that vary quite a lot over the time period, but have generally gotten better over time. The rates of GVHD are much higher, generally speaking, in our other types of donors, so our matched unrelated donors, particularly for sickle cell disease, because our donor population for stem cell transplants that are not related to patients tend to be of quite different ethnic backgrounds than people receiving transplants. Haploidentical donors, everyone, if you have a living family member, will have a haploidentical donor potentially. So this is a really promising area of upcoming research, is looking at haplodonors, but the existing research from prior to 2020 has been somewhat limited by rates of GVHD and slightly lower event-free survivals. A little bit about donor types. Different donors make for different outcomes. Matched sibling is best. This looks at data from, again, CIBMTR, which is the Center for International Blood and Marrow Transplant Research. And it's looking at the number of transplants for sickle cell disease over 2015 to 2018. And we can see that excellent overall survival with HLA identical matched sibling donors. But again, we can also see the haplo transplants are looking pretty good here. The same slide for thalassemia. Again, HLA identical siblings have the best outcomes. I just want to take some time to talk a little bit more about the risks of curative therapy, because we know it's great, it's wonderful, and it's a cure if you can get through it and tolerate it well. There is a preconditioning optimization phase for our red cell disorders. So it's generally hypertransfusion to suppress erythropoiesis for thalassemia. And it's hypertransfusion and hydroxyurea to suppress hemoglobin S production in sickle cell to try to make the transplant period as free from particularly vaso-occlusive pancreatitis as possible. And ideally, we want to identify patients without existing organ damage or have optimally chelated these patients to have the smoothest transplant process. Conditioning complications, I'm going to talk about a little bit more in a minute, but those can include infections, organ failure, or secondary malignancy related to the conditioning. Graft failure is what happens if that allogeneic graft isn't able to actually establish itself in the bone marrow of the host. And graft versus host disease is when that new donor graft identifies the body as foreign and goes on to attack it, which is managed with immunosuppression, which can further potentiate infectious risk. There are deaths associated with these therapies, though thankfully the risk of death is generally less than 5%. This is from CIBMTR and shows pediatrics in the top two graphs and adult populations in the bottom two graphs. The first on the left is patients who died within 100 days of transplant, so the early period, and the second is beyond 100 days. These are all transplants, so these are not specifically red cell transplant data, and that's why such a large population of the deaths were actually associated with primary disease in this darker blue number. What I wanted to show with this slide is the amount of death related to particularly that conditioning therapy, including infection, organ damage, and to some degree GVHD, because GVHD can have to do with the conditioning as well as the donor type that's used. So you can see that infection in the light blue, organ failure in the chartreuse green, and the peachy colored GVHD makes up most of the early deaths and almost half of the later deaths in adult populations. Most people do not die, but the risk of death is real and often associated with conditioning. Conditioning, as I said, is to make space for that graft. It essentially induces some degree of pancytopenia. It is interesting to note that T cell depletion is particularly important to reduce graft versus host disease. T cells are very important in malignant transplants to have a graft versus tumor effect, which is shown on top of this left facing arrow in the picture here. That graft versus tumor effect is not advantageous in non-malignant, like red cell transplants. Two of the conditioning regimes that are common include total body irradiation, or TBI. At high doses, TBI can be associated with gastrointestinal, hepatic, lung toxicities, as well as secondary malignancies. Alkylating agents like busulfan are also very common, and those can cause hepatotoxicity and veno-occlusive disease, as well as an increased risk of secondary malignancy. Conditioning, there is so much that can be said about conditioning, and you need an expert who knows transplants in and out to decide on the best thing based on literature, based on site experience, and many other factors. But there are conditioning therapies with reduced intensity, sort of like this TBI at the bottom, that have less toxicity. With higher intensity, you generally get higher toxicity. Sometimes we need to be myeloablative. We need to go in and wipe out everything of the host's immune system, which can actually help the new graft settle in better. But this is often more toxic. Standard myeloablative therapies include busulfan and cyclophosphamide, sometimes with ATG, sometimes with some radiation. It is mandatory for gene therapy at this time, based on the trials that we have, to use busulfan for conditioning, which is concerning with hepatotoxicity in some cases. Non-myeloablative or reduced toxicity regimens can be helpful in terms of giving transplants to sicker patients who will tolerate it better due to reduced toxicity, but sometimes this makes it harder for the graft to actually become dominant, and you may end up with mixed chimerism, which is when you have some of the immune system of the graft and some of the immune system of the donor. That may not be the worst thing, because having even 20 to 40% of donor cells in the bone marrow can be associated with prevention of complications. Very briefly, graft failure, as I said, is when the new transplant isn't able to set up shop. This can also happen with gene therapy, where the gene therapy product isn't able to expand and grow in the bone marrow. Graft versus host disease, I've talked about a few times, and there are T-cell depletion either in the actual transplant or in the donor, or sorry, in the recipient, can help reduce the risk of graft versus host disease, as well as better matched donors. So matched sibling donors have the best match because any tiny little polymorphisms in their HLA genes should be identical within the family. Graft versus host disease can be very scary, but we have seen a decrease overall with our newer therapy and knowledges and things. The type of graft, whether it's cord blood, peripheral blood, or bone marrow, collections can have an effect on graft versus host disease, though the, again, newer therapies are processing this better and reducing that. So we've seen a shift towards apheresis collections of peripheral blood stem cells. So that is much easier on the donors, who can come and sit with an apheresis machine for a day or a couple of days and have collections, rather than having to come and have multiple bone marrows in one day. So bone marrow transplants, we need people to be sick enough to benefit from bone marrow transplant, but not so sick that they will not tolerate the conditioning. We want to have a matched sibling donor, which about 20% of people will have. And we can use trait. So patients with trait status, siblings with trait status can donate. There's been a recent trial that was quite promising, looking at 31 patients with haplo transplants. So this is what I mean by it's coming. We're getting better at transplants. Good progress is being made. But not everybody has a matched sibling donor. So gene therapy is a very attractive future for that, particularly, or for people who, if we can make gene therapy even better, it may be less involved. Two main approaches to gene therapy exist, either trying to insert a new functional gene or trying to actually modify the existing structure. So that's generally using something to turn on fetal hemoglobin expression, which I have pictures for, which will be great. One of the things important is our ex vivo gene therapy that we're doing now is very much like a transplant. There's a run-in with transfusions to try to suppress sickle cell disease complications. They have to go through collection. You can't use GCSF for mobilization in sickle cell patients due to increased risk of crisis. So it's hard to get enough cells. These cells have to be processed, and that can take weeks to months. The conditioning is still the main association with negative outcomes. And the current trials require busulfan for myeloablative conditioning. After you've been conditioned, you get reinfused with your gene therapy product, and then it can take up to a month for that to actually engraft and start functioning well. Usually you're in hospital during this time. So the first therapy that I want to try and talk a little bit about is this is a gene insertion. So they select CD34 positive stem cells from the patient, and they use a lentiviral vectored DNA for a globin chain that is expressed. The one that they're looking at here is hemoglobin A T87Q18, and they developed this globin gene specifically to be anti-sickling, so it helps prevent that polymerization that happens to change the conformation of cells in sickle cell disease. The numbers actually look pretty good for this, albeit in small numbers of patients. So this is long-term follow-up with 7 patients who received this lentiviral vector globin gene. And you can see that there is variable but persistent expression over a long time. You can see 48% of hemoglobin in this excellent first sickle cell patient is this T87Q. And you can see that 78% of this thalassemia, transfusion-dependent thalassemia patient 2 over here. The lentiviral vectors they're retroviruses, so they integrate into the DNA in specifically targeted areas. But this leads to that concern over insertional mutagenesis, where could the vector incorporate in the wrong area of a cell and cause that cell to go on and become malignant. And they actually held trials for a period of time in 2021 due to a sickle cell patient developing AML 5 years out from transplant, and a second patient developing MDS. It was ultimately decided that neither one of these was related to the actual lentivirus vector. It was not expressed in the acute myeloid leukemia cells. And we know that patients with sickle cell and ineffective erythropoiesis are at increased risk of leukemia at baseline. And things like busulfan and alkylating agents that we're using in conditioning are associated as well with secondary malignancy. So nothing in life is free, I guess is where I'm going with this. And the fact that these therapies are very promising, very exciting, but there are potentially significant side effects, though the cancer in these were not related to the lentivirus itself. It was due more to either the underlying patient or the conditioning chemotherapy. We're still using conditioning chemotherapy, myeloablative therapy with busulfan for CRISPR-Cas9, but CRISPR technology where you're able to go in and edit a gene specifically is very exciting, because we can program these DNA targets quite easily and then use an endonuclease like Cas9 or Cas12 to go in and snip and disrupt that gene. So the therapy to increase fetal hemoglobin is based on disrupting the BCL11A gene. That's a negative regulator of hemoglobin F. So if you knock out your BCL11A gene, the body undoes that switch from fetal to adult hemoglobin and starts producing your own hemoglobin F. And we know from hydroxyurea that that is a very effective way to improve outcomes in hemoglobin in patients with sickle cell disease. So that was why they chose this target. And it's exciting because we can make different targets quite quickly if we find other promoter regions or things that we want to target that way. So this technology is very flexible. The CRISPR-Cas9 is an ex vivo, so out of the body gene therapy, because that the protein is quite large, and we're worried if we infuse it into a person to try to make this happen in a person, that protein is large and may be immunogenic and would get cleared too quickly. This also works really well. You can see this hemoglobin F increase from 0.3 before infusion of this particular gene therapy product, becoming the majority of the hemoglobin over time. The first patient is a transfusion-dependent thalassemia patient. The second patient is a sickle cell patient, and you can see the relative suppression of hemoglobin S with the production of hemoglobin F. So this also is capable of durable increased fetal hemoglobin responses. This particular CRISPR-Cas9 has been studied in about 35 patients all total. Excuse me. I spoke a little bit before about it does not fix existing damage. And I just wanted to highlight these two things, is that there are still pain crises post curative therapy, generally only in the first year, and they generally settle down over time. But these red bars show patients with a vaso-occlusive event or vaso-occlusive pain, hospital visit or admission occurring after the first year post-therapy. So there are a proportion of patients with sickle cell disease who even post-cure will not have complete resolution of pain crisis, particularly patients with chronic pain are more likely to be in this population, and it may be things like AVN, etc. Usually it takes more severe triggers, so they're not as likely to have an episode of pain. It takes a more significant trigger to actually result in a hospital admission or an overt pain crisis. But knowing that it's not perfect for absolutely everybody, though the vast majority have a significant reduction in vaso-occlusive events, particularly beyond the first year. Another interesting thing that popped up in my readings was that there's actually an increased risk of suicidality post-cure. This occurred in a cohort of 14 patients. 43 of them actually expressed suicidality and suicidal intent or thoughts, despite having excellent transplant-related outcomes, 100% engraftment. They noticed this most in the patients who had had a history of chronic pain or frequent admissions, or who were undergoing significant medical or psychosocial stress. They didn't touch upon whether this might be due to the identity proportion of this, of some people who live their entire life and their identity is sickle cell disease, and now they're cured. And things should be better, but the road to recovery is often a little bit longer and more challenging than people are sometimes expecting. But I want to talk a little bit about what this means for us. So I think the opportunity for curative therapies is now. I think it's very exciting to see gene therapy come from, what seems like science fiction to the bedside. It is currently only on trial, and I think that's quite reasonable for the time being, to make sure that we're understanding what the implications and the long-term implications of these therapies are. But it's such a great opportunity to really meaningfully change the lives of our patients. And I think the amount of discussion and buzz happening right now is important to leverage for new therapies, new targets, new ways to help fight these diseases, as well as to advocate for our patients and their needs. The evidence is based on small numbers because these are relatively rare diseases. So Vertex got its FDA approval based on 35 sickle cell patients for the Cas9 BCL11A gene therapy. These patients need specialized care. They need care from a red cell clinic, but they also need someone who knows about cellular therapy, who's an expert in transplant and or gene therapy. We need our patients to be sick enough, but not too sick. And that often for our sickle cell patients means some evidence of end organ damage to know they have a severe enough phenotype to balance the risks of that conditioning therapy, of, you know, the time in hospital, infections and all of that. But we don't want them so sick that they have damage that would preclude them from having a good outcome. There are issues in equity and access, as well as medical mistrust based on historical context. And the cost of gene therapy is incredible. Transplant costs around $200,000 American for the transplant, and gene therapy is 2 to 3 times more costly than that, because it's essentially the cost of an allogeneic transplant plus manufacturing. Though perhaps local options and Canadian-made therapies may help reduce this. As promised, there are only 13 specialty red cell clinics in Canada, according to the CanHeme website. There are 4 in Ontario, but notice that there's none in PEI and none in our territories. These specialty clinics are generally centrally localized, but many of them, like Hamilton, has experience with malignant transplants, but we're not in a position to do red cell transplants in Hamilton at this time. So even though we have red cell expertise, we're still consulting our patients to Toronto, to another clinic. But I think there's good opportunities. I'm super excited to learn about more research about antibody-mediated conditioning regimens and regimens that are with reduced intensities and ways to help reduce that risk of conditioning. There's also lots of opportunities for Canada to decide if we go forward with gene therapy, and the companies are putting these forward for Health Canada approvals. Who should be responsible, and how can we make sure that our patients have access to top-of-the-line care in an appropriate and equitable way? Do we want Canada Blood Services to be in charge of this? How that should work is an amazing opportunity that we have going forward, because none of these gene therapy products are currently approved in Canada. I think the most exciting thing, though, is if we can find a way to do in vivo gene therapy, where you give people an injection into their body and it fixes them without the need for extensive conditioning, hospital stays, risk of infection conditioning, and all of that. So I'd like to hope that we can keep continuing working on this. There are some ideas in the pipeline. So that's my talk. I hope that we went briefly through thalassemia and sickle cell disease, that we talked a little bit about curative therapies and some of the future directions and Canadian context. Thank you.
Thank you so much, Sarah, for this amazing overview of the current, future, what we do and we don't have. Lots of thoughts. If you have a question, please write it in the Q&A or in the chat. And if you would like to ask your question in person, please raise your hand and I'll bring you in. And we have Dr. Dorsami. Here you go, Panji, go ahead. I can't hear you, Panji, if you're speaking. You're muted. Sorry.
Thank you so much. Thanks, Khalid, and thanks, Sarah, for that lovely presentation. I'd just like to mention the association of sickle cell disease and pulmonary hypertension. There's an interesting relationship, and I'd just like to, even though we know that pulmonary hypertension is a rare condition, my first case of sickle cell disease and associated pulmonary hypertension was about 18 years ago when I first started the PH clinic, and in fact, was a patient that was referred to me as having sickle cell disease and having had a previous pulmonary embolism, and it failed anticoagulation. And this patient was getting short of breath and eventually came to my PH clinic when they found he had a slightly elevated RVSP. And so I investigated further, and in fact, he turned out to have chronic thromboembolic pulmonary hypertension. I referred him for a pulmonary endarterectomy, and in fact, up to today, which is now almost 18 years ago, he's doing extremely well. He's had a number of problems in the meantime, he's even had a lung transplant. I mean, he's had a kidney transplant and a number of other problems he's had, but he's actually gone through that quite nicely. And in fact, he's responded well to his surgery. But I want to mention the association. Now, there are different mechanisms whereby patients with sickle cell disease can get PH, and I'm not going to go into the details of that, but much of which is actually related to hypoxia and the consequences of hypoxia with all the endothelins and other factors that are elevated. But what's interesting is the prevalence. So if you take a group, and this largely comes from data that I can remember from the US, from the US PH Association. If you take a group of adults with sickle cell disease, the prevalence of PH is about 10 to 30%. But in addition, when you looked at, from the same association, when you looked at their autopsy data, about 75% of patients that they looked at autopsy in patients with sickle cell disease, about 75% of them had pulmonary hypertension. So it's always important that, when patients with sickle cell disease, if they get short of breath, it's not necessarily their anemia, but they may have, in fact, pulmonary hypertension. It's always useful to get the echo and to get the VQ scan just to make sure you're not dealing with CTAF as well.
Thank you for your comment.
That is very, very true and very challenging. The pulmonary hypertension, the chronic hemolysis, hypoxia, all of it contributes, and we do see it, and it's a terrifying side effect or like complication of sickle cell disease, and something we screen for before we transplant our adults.
Very good. There's a question from Dr. Shulman related to the what's the longest observation time so far after CRISPR-Cas9 therapy? Do you think this will last for life in terms of an effect?
So we're definitely hoping so. It's been a couple of years. Those the two patients that I showed were in that graph were the first two patients to get that CRISPR-Cas9, and that was from, when was that published? 2021, but that was a couple of years out. So they're a couple of years out. We're hoping that it's going to lead to a durable expression. And it seems to be durable over time, but the individual expression is not always totally consistent. We're hoping so. So we have a couple of years of data. More data is coming through all the time. But it seems like it's going to last a lifetime. We don't know. So the current FDA suggestions for gene therapy are that we study patients for 15 years at least.
That's great. My understanding, so are these gene studies currently not available in Canada, even in research form? They're all just in the States and Europe, as we were chatting earlier.
So there have been trials that have involved Canadian patients. There is Editas is a trial currently in Toronto for beta thalassemia. So that there are Canadian patients on some of these trials. There is no gene therapy that has yet, I don't think it's even been submitted to Health Canada for approval, though Vertex and Casgevy, which is the one that was approved in November in the UK and then December in the States, is definitely thinking about it. Our population of sickle cell disease is not small, but not big either. And we're geographically quite spread out. So the companies that are doing the gene therapy are spending some time thinking about whether the market is going to be profitable for them. So they're very interested in helping patients. That's not the problem, but they're, at the end of the day, companies. So we are hoping that they find it meanwhile worthwhile to invest in Canadian centers. There's still a lot of discussion that needs to go on as to, again, who's going to do this, because you need somebody who's experienced with cellular therapies. There's some overlap with CAR T, so we're hoping that centers that are providing CAR T therapy for malignant conditions may have the expertise to help do this. But a lot of the transplants are in malignant hematology, which is its own area that is changing day by day with new research. and the sort of advancing research in red cell disorders and the advancing research in transplants at this time, you really need both experts together. So it's only available on trial right now in Canada. Our hope is that we will get approved therapies, but there's a lot of hoops that need to happen between now and then.
Fantastic. There's a question from Dr. Raza Mirza. He comments, the opportunity for cure is always exciting, yet it's still early days. Are there insights we can draw from more mature gene therapy literature that may help us predict how things may eventually evolve? Example, in severe combined immunodeficiency disease.
A lot of the new developments of the targets of gene therapy, and whether we're using zinc fingers or Cas9 CRISPR or CRISPR Cas12, and even the opportunities for ex vivo in vivo gene therapies are based on what we know from existing literature, what we know from our sickle cell populations, and looking at that together. I'm not someone who develops gene therapy trials, but the existing data is very much, we look at our disease-specific thing, but we also are looking at other gene therapies for particularly blood and immune system disorders that involve the whole body, because there's a lot of overlap there and a lot of lessons to be shared and learned regarding conditioning, regarding optimal process, regarding targets and how to best manipulate those.
That's interesting. You've touched on this a little bit, but I can see how health equity plays a role in this disease, as well as, interestingly, in the treatment as well, and the consequence of the treatment. I mean, talking about the prevalence of suicide following curative therapy is really fascinating, and try to explain it in terms of how this disease is more of a lifestyle and so complex. So any further comments on health equity in the treatment, especially curative therapy, especially if we talk about gene therapy and accessibility, it's going to be excessive, and especially when I was in the States, but it arrives to Canada. So any thoughts on that?
So many thoughts on that. I mean,
you have 2 minutes.
2 minutes. I know. I think the equity of access is going to be probably the biggest thing, because there are essentially some provinces that are going to have to send people to a totally other province to receive care. And I think we need to be proactive in managing that to ensure that wherever you live in Canada with one of these diseases, you have access to standard of care and appropriate care. So from a gene therapy stem cell transplant, I think access is something we need to be proactive as a country about, for all that most of our healthcare is provincially mandated. That won't work for this, I think. I do think it's really important to remember the multifaceted challenges that a lot of our patients with sickle cell face. This is a painful disease. It often looks silent. It affects young people because it's genetic and from birth. So when you have, a 22-year-old person in the emergency room telling you that they have excruciating pain, but they're playing on their phone because it's chronic pain and they're just trying to distract their brain, please listen to them. When they tell you, I need 4 milligrams of Dilaudid because that's the dose that works for me. I mean, use your brain. I'm not saying to disregard your judgment, but when someone with sickle cell has been battling this their entire life and comes into the emergency room with their own advocacy to say, this is what works for me in this situation I've been dealing with my whole life, it does not mean they're a drug user. And the rates of inappropriate opioid use and opioid use disorder are not elevated in populations with sickle cell disease. They are the same rate as baseline populations. The same rate as baseline populations, not patients with chronic opioid, on chronic opioids. Like, it's not elevated compared to the general population. So please be nice to our patients. They're very important to us. We're a team and we like to be part of the team.
Yeah, and I can see the importance of that. Thank you very much, Sarah. This has been very interesting and informative. Great coverage and exciting future for this difficult disease and population that's suffering through it, and thank you for that touch on health equity importance here. Thank you, everyone, and I wish you all good rest of your day. And until next week, you have a good weekend as well. Take care. Thanks.
Awesome. Thank you so much.